Greetings, class. Today we're going to discuss Chapter 2. Um, Again, I'm just going to hit up the highlights of Chapter 2. And really, the basic purpose of Chapter 2 is discuss the government's role in healthcare, particularly how the government is a payer, regulator, and provider of healthcare services. We're really going to spend most of our time talking about the government as a payer and a regulator, and we're going to talk about the provider side of healthcare later down the line in the course. So the government is a payer. Again, we're just going to hit up the highlights. As we've discussed in previous chapter and most likely in class, the cost of healthcare in the United States is increasing at an unsustainable rate, and something has to be done about it. Where the government fits into everything. And this is just a slide that I believe I showed this video in class already. If I haven't, then I will, but feel free to watch it. It just illustrates, how much money really is $1 trillion. We see the cost of healthcare getting thrown around all the time. 2.6 trillion, approaching 3 trillion. Some people and economists think we already spent 3 trillion on healthcare in 2013, and this sort of illustrates to you exactly how much $3 trillion is, and it's a lot of money. This is where we're going to stop for a couple of minutes. We really got to understand who's covered by health insurance and who is not covered by health insurance in the U.S. This will really be able to build a good foundation of why the cost of health insurance and the cost of healthcare as a whole is so expensive. So when you look at this chart right here, this illustrates the percentage of the U.S. population and who's covered by what type of health insurance. And then, of course, at the bottom where it says uninsured right here, that means obviously those that do not have health insurance. Private health insurance is, of course, the money that you spend out of your pocket to purchase health insurance. And that is, most of it is purchased through work, through your job, through a group health insurance plan. You work at, say, Baptist Health, or you work at Budweiser, or whatever the employer is. That employer will offer employees a group health insurance plan. And we're going to get into that in the next chapter. But this chapter, we're going to more spend our time discussing Medicare and Medicaid. And as you can see, percentage of the population in the U.S., almost two-thirds, well, really two-thirds of the population is covered by private health insurance. The other one-third is either covered with Medicare, Medicaid, or they're uninsured. And if you look down the line here, the thing to keep in mind is, let's just look at 2008, the orange graph, 66% covered by private insurance, 14.3% of the population covered by Medicare, 14.1% covered by Medicaid, almost 4% covered by some other government plans, and then 15.4% uninsured. But if you add all those numbers together, you don't get 100%. Actually, you get more than 100%. So keep in mind the reason why that is because there's a lot of people that are covered by more than one entity here. So, for example, you can have private insurance and also have Medicare. You can have Medicare and also have Medicaid. Odds are somebody who has private insurance does not have Medicaid. Somebody that has private insurance, obviously they're not uninsured, but there are people who have dual sources of healthcare insurance. Private and Medicare, somebody can have both. Somebody can also have Medicare and Medicaid. So keep that in mind when you look at this graph. Pretty interesting graph. The thing to take away from it is that in 2008, 15.4% of the U.S. did not have health insurance. In 2013, that number actually reached 16.7%. So it was on the rise between 2008 and 2013. And what we should see in 2014 and beyond is that this uninsured number here should decrease as Medicaid, Medicare, and private insurance start to increase. This right here shows the percent, let's see, a percentage of workers covered by their employer's health benefit. Okay, so about 60% of the U.S. population has health insurance through their employer. Okay, the important thing to take away from here is that large firms down here, employers that employ 200 or more workers, okay, of everybody in the U.S. that works in a large employer, only 63% of them choose to get health insurance. So what that says is that there's a large number of people, of employees that work at a large company that are offered health insurance and choose not to get it. So in 2010, that was about 37%. So about 37% of U.S. citizens that work for a large employer, 37% of those people chose not to get health insurance. And that's an important stat to keep in mind, because now as we move forward into 2014 and beyond with the new Affordable Care Act provisions that are in there, if you work for a large employer, you have to get health insurance. So that 37% that chose not to get it in 2010 are now under law, they have to buy health insurance. And we're going to get into that in a couple more classes down the line when we talk about healthcare reform and we talk about more about private insurance. But that's an interesting graph to look at, is that, again, takeaway from this is that 37% of the U.S. Population in 2010 chose not to get health insurance. And that fed into this uninsured rate down in here, while we have such a large uninsured gap in the U.S. So interesting stat right there of there's a large percentage of people that have health insurance available to them through the private insurance market, but choose not to get it. So again, what we're going to talk about and spend most of our time on is the government as a payer, particularly as it relates to Medicare and Medicaid. The cost of health insurance, again, the cost of healthcare as a whole is going up at an astronomical rate in the U.S., which means that the government is spending more and more of their fiscal budget on Medicare and on Medicaid. And if you look at this graph right here, this was in fiscal year 2010. The government's budget as a whole to run the government and all their programs was $3.5 trillion. 15% of that was directly spent on Medicare. So if you take out your calculator, which I'm doing right now, you look at 3.5% and multiply that times 15%, sorry, 3.5 trillion. So that comes out to $525 billion the government spends on Medicare. That's a lot of money, man. That's a lot of money. And of course, where does the government get that money to pay for Medicare? Well, tax dollars. We, the tax-paying citizens, this is what we're paying for. Our tax dollars are going to Medicare. And as we've moved forward by 2020 to 2040, the baby boomer generation, more and more baby boomers are going to be retiring, and they're going to be reaching Medicare eligibility. And so you'll see this number right here, that half $500 billion or 15%, that number is going to go up, and it's going to go up a lot. So there should be cause for alarm in the Medicaid program, because many healthcare economists think by the year 2040, some think sooner than that, by 2030, that the Medicaid program is going to be insolvent, meaning that all of a sudden, well, not all of a sudden, meaning that by 2040, some think by 2030, some think by 2035, that the Medicaid bank account, if you will, that the government has is going to be zeroed out. There's not going to be any more money for it, or Medicare is going to go belly up. Medicaid is a little bit different, a lot different than Medicare. Look at Medicaid like it is a social welfare program ran by the states. Medicare is for older, 65 and older retirees, okay, and also disabled Americans. That is a federal government program, Medicare, okay, meaning that that is a blanket program covered by anybody that meets the age and also disability requirements can qualify for Medicare, and it doesn't matter what state you live in. The federal government regulates Medicare and pays Medicare. Medicaid, okay, is a different program that is ran by the states individually. So look at Medicaid as if it is a state-ran medical medical program that you have to have an income restriction in order to qualify for Medicaid. Okay, it's a social welfare program in a nutshell, ran for and paid by the states, but the federal government partners with states, and the federal government gives states money to help keep their Medicaid program up and running. Okay. Medicaid enrollees, the number of people that are eligible for Medicaid has grown a lot since 1990. So over the past 20 to 30 years, the amount of people that are being enrolled in Medicaid, that are eligible for Medicaid, has grown a lot. And if you look at it right here, it's these two groups of people, children and adults. Okay. Now, there are some elderly and disabled that have increased in Medicaid, but the largest group of people that have become more and more eligible and that have been enrolling in Medicaid since 1990, if you look, is children and adults. Okay, and it's increasing at a pretty large rate as well. The thing that we need to be concerned about is the amount of people that are enrolling in Medicaid before 2014 has increased, okay, while state budgets and state revenue has decreased. So the cost of Medicaid has been going up because the amount of people enrolling has directly gone up at the same time that state revenues have been going down. So in order to offset that, what the states have done is they have taken new enrollees in Medicaid and put them in what's called a managed care program. Because of declining state revenue and the amount of people and costs of state Medicaid program increasing, states have had to try to find a way to offset the large cost of Medicaid. So what they're doing is they're putting people in managed care programs. And you can look up what the definition of a managed care program is in the textbook and also in the supplemental readings. But in a nutshell, a managed care program is the state will pay sort of like a managed care company, let's say like Blue Cross and Blue Shield, if you will. At Blue Cross and Blue Shield, at that insurance company, what the state of Florida will do is that they'll pay Blue Cross and Blue Shield, they'll pay like some nurses at Blue Cross and Blue Shield to manage the care of Medicaid recipients in the state of Florida. So when a Medicaid patient goes to see a Medicaid physician, when the physician orders tests, orders MRIs, orders care, what happens is that those orders go to that Blue Cross and Blue Shield managed care department. And so nurses will sit behind a computer and they will review the patient's chart. And then they will either say, yes, this patient is approved for XYZ, or no, the patient is denied XYZ based upon, whatever the reason is that the nurse would be approving and denying particular claims. So Medicaid enrollees are now being shifted towards managed care. Okay, and there's a lot of controversy around that. Having somebody in an office or having a nurse sit in an office that is saying, yes, you can get a certain, yes, patients can get a certain treatment, or no, this patient cannot get this certain treatment, or they cut the cost of a particular, or they cut the reimbursement of a particular treatment. There's a lot of controversy around that, but the thing to take away from this slide is that with the increase of Medicaid enrollees and with the decreasing amount of money that states have to pay for these Medicaid enrollees, what the states are doing, like the state of Florida, is that they're pushing all these new Medicaid enrollees into managed care plans in order to cut costs of Medicaid programs. So in a nutshell, we'll get into this in class so you can understand, and then you can also go back into the textbook, because the textbook does a pretty good job of getting into the ins and outs of Medicaid, to build sort of to build your knowledge base, if you will. Medicaid, in a nutshell, it's not a single program. It's not a single national program. It's a collection of 50 state-ran programs that, in order for somebody to be eligible for Medicaid, you have to meet the income restrictions. You have to be poor. Okay. In a nutshell, it's a social welfare program to get on Medicaid, and that's really sort of how how a lot of people in society view it as. But it's like one of those things to where, if you're poor, you have a limited amount of income, and you don't have health insurance, the state will give you a Medicaid health insurance program that covers basic necessities, and it's like you either have the choice, either you get nothing or you get something through the state. And so a lot of people, that's all that they have. That's all they have available to them is Medicaid. And the thing about Medicaid is that when you're eligible for Medicaid, you don't have to pay for it, meaning you don't pay a premium. Okay, and if you don't know what a premium is, go to Blackboard and go to the additional resources section, and then there's a healthcare terms reading in there that tells you what premiums, co-pays, deductibles, and coinsurance, and explains what all that is. But that's the thing about Medicaid, is that because you live below the federal poverty line, and then you qualify for Medicaid, you don't have to pay for it. The state pays for it, but it's really limited on what you can get. And there's a lot of research that shows that the quality of care for Medicaid patients is actually pretty low compared to the quality of care that somebody would get if they had a private health insurance plan. Excuse me. And one more thing that I'll say about Medicaid is that even though it's a collection of 50 state-ran programs, eligibility differs from state to state, meaning that somebody that qualifies for Medicaid in the state of Florida doesn't necessarily qualify for Medicaid if they move to Mississippi, or they move to Maine, or they move to California. Eligibility requirements differ from state to state. Okay. The federal government does contribute to state Medicaid programs, and it varies from state to state. Basically, the states in the Northeast that have more money, the government contributes less to their state Medicaid programs, and states that have less money, such as some of the Southeast states, Florida, Mississippi, Georgia to some extent, but really Mississippi and the Panhandle states, or the Gulf Coast states, if you will, those states have less money in their budgets, and so the federal government contributes more to their Medicaid program. Medicare is different than Medicaid. Medicare is what's called an entitlement program, meaning that when you live in the United States and you reach 65 years of age, you are entitled to Medicare. It's not income restricted either. You can have private health insurance. You can be rich, okay, and you can still qualify for Medicare. And a lot of people do, a lot of elderly retired folks do have Medicare and also some sort of private health insurance, maybe through a retirement plan through their employer. Some elderly retired are dually eligible, meaning that they have Medicare and Medicaid and use both of those health insurance types to try to get better healthcare services. And then there are some disabled people in the United States, disabled folks that also qualify for Medicare. And again, it's regardless of income. You have to meet disability definitions, and you also have to meet an age requirement in order to qualify for Medicare. It's the closest thing to a social insurance program that we have in the United States. And we've heard that thrown around a lot, especially over the past couple of years since the Patient Protection and Affordability Act had passed, or healthcare reform, if you will, or Obamacare, quote unquote, has passed and become very popular in the mainstream media. Medicare is a form of social insurance, meaning that we do use taxes to pay for it. And anybody who is 65 or over right now qualifies for Medicare. When you qualify for Medicare, there are 4 parts of Medicare: Medicare Part A, B, C, and D. And we'll talk about those in a minute. Depending on what you qualify for, you can pay a premium every year in Medicare, and you can get additional insurance coverage. Okay, when you turn 65, Medicare Part A, I'm getting ahead of myself, so we'll get to that. Medicare Part A is free. Medicare Part B you have to pay for, Part C you have to pay for, and Part D you have to pay for. And so the reason I bring that up is because the premiums, all right, whatever you want to purchase through Medicare, the premiums that a person has to pay out of pocket in Medicare is heavily subsidized by the government, meaning that somebody, after they sign up for some plans in Medicare, at the end of it, whatever the bill is, the government may pay up to 2/3 of that annual premium, which leaves about 1/3 of that premium left to the actual Medicare recipient. So, the government pays a lot of those premiums for Medicare recipients. Okay, it's administered by CMS, or the Centers for Medicare and Medicaid. Right, that's a branch of the government that oversees Medicare and Medicaid. Medicare is funded directly by a tax on the current workforce in the United States. Okay, when you look at your paycheck stub, there is a FICA tax that comes out of your paycheck. That FICA tax that is automatically deducted before you get your money from your employer out of your paycheck, that FICA tax is a Medicare tax. Okay, it comes right out of your paycheck, and it's a percentage of your paycheck. The more money you make, the more FICA tax you pay. The important thing to keep in mind here is that the baby boomers take up a huge percentage of the workforce right now, and of the general population. Right now, as it stands, for every 4 workers in the U.S. Workforce that is working and paying a FICA tax, for every 4 workers that's paying a FICA tax, there is 1 Medicare beneficiary. So look at it like, for every 4 people working in the workforce, those 4 people pay for one person to sit back and collect Medicare and to have their Medicare paid for. So 4 people pay for one person right now um, 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 in our healthcare system. By the year 2030, with all of the baby boomers that's aging out of the workforce and going into retirement, that 4-to-1 ratio is going to decrease to almost in half. By 2030, instead of having 4 workers pay for one Medicaid enrollee, it's going to be 2.3 people paying taxes are going to be paying for every one Medicare enrollee. And that's huge because the cost of Medicare is going to go up, and with the cost of Medicare increasing and the cost of care overall increasing, you're only going to have 2.3 workers in the United States workforce paying for one Medicare enrollee. And we'll get into more in that in class, but that is a huge problem. Okay. So with the costs of Medicare going up, what you have to find ways in order to make the amount of money that we have in the national Medicare bank account, if you will, paying for Medicare. We gotta find a way to make that money work. And so what's happening is that the government's cutting physician reimbursement, they're raising taxes, and they're also going over to China and borrowing more money in order to pay for Medicare costs. Okay. And when this happens, that's significant because just because of the sheer size of Medicare, with the amount of cost and also the amount of lives that it covers, when you cut reimbursement in Medicare, it's going to have huge policy effects over the private health insurance market. And also it's going to have huge effects on the quality of care further down the line. So that's huge, and we're going to get more into that in class. Also, the textbook talks about that. Okay, we know the cost of Medicare is going up, and all outlays, all that means is the total cost of Medicare. And so if you look at right now, okay, 2013, 2014, and I had said before, it's about 570, 550, 575. This right here was an estimated cost at time that our textbook was printed. And so they had estimated $652 billion. Okay. But by 2020, we're going to be approaching $1 trillion in Medicare costs. And again, that's an astronomical number. That's about 1/3 of the cost of our entire healthcare system. Okay. And so what's trying to happen, what the government's trying to do is trying to push people into managed care plans as well. And that is, where's that chart coming up here? We'll get into that as well. But I'm getting ahead of myself. So what we're going to spend time talking about right now is there are 4 parts of Medicare, right? A, B, C, and D. And each one of them covers a different healthcare, a different part of the healthcare system, if you will. Part A covers hospitals, okay, hospital inpatient care. So if somebody is admitted, somebody who has Medicare and they're admitted to the hospital, okay, the charges associated with hospital inpatient care, if they have to stay overnight, Medicare Part A covers. Medicare Part A is free to Medicare enrollees. You don't have to, traditionally they don't pay a premium on that. And that's going to change moving forward. Part B covers physician services. And so you can choose that to add that to your Medicare Part A, to your Medicare coverage, but you have to pay a premium for that. Medicare Part C is what's called, it's a hybrid. There are so many different options available to a Medicare beneficiary through Part C. You can pick, it's basically you pick a plan that you want and then you pay the premium. Medicare Part C being a hybrid, it takes Part A and it takes Part D, which is prescription drug plan. Okay. It takes all sorts of different types of coverage and it lets the enrollee pick what they want in their health insurance coverage. It's really like it's a private health insurance plan. But the difference, like with private health insurance, how you can pick what you want, you can pick an HMO, a PPO, a high deductible plan, and we'll get to that in the next chapter. But Part C really lets the Medicare beneficiary choose what they want to have covered in their Medicare plan. And of course, they pay a premium for that. Okay, they pay a price. But the thing about it is that the government pays a huge percentage of that premium. So the government is almost like a participant with the Medicare enrollee because the government pays for a nice chunk of their premium. And of course, Part D is the prescription drug plan. This gets into premiums, copays, and deductibles. A lot of changes have happened recently over the past 5 years, and it's going to continue to change moving forward with Part A, meaning Medicare Part A, which is inpatient coverage. This right here, and this is just sort of FYI, I don't test you on this right here, but previously, you didn't. A Medicare beneficiary did not have to pay for you didn't have to pay a copay or deductible or a premium for their Part A Medicare plan, but that's all changing now moving forward. This, like I said, this is just FYI. We're not going to get that deep into it. I had mentioned before that the government, in order to try to control costs of the Medicare program, just like what they had done with the Medicaid program, let's see, that's number 23, and I'll refer you back to this right here. Remember I had said before is that when a Medicaid beneficiary, when they sign up and they're granted Medicaid healthcare coverage, because the states were spending so much money, or it was such a huge part of their budget, like the state of Florida, for example, they're trying to place Medicaid enrollees into managed care programs, meaning that there's a nurse sitting in an office that approves or does not approve certain types of coverage, right? And manages their care. And with Medicaid enrollees, they really have no choice. It's either, you have Medicaid or you don't. They don't really have a choice in it. And so that's why it's not really that great of a coverage plan, but it's better than nothing, so to speak. Versus this right here, trying to get Medicare enrollees, Medicare beneficiaries enrolled into managed care programs was a little bit more difficult, because at the end of the day, Medicare beneficiaries do have a say in it. They have skin in the game, meaning that they pay for their premiums, copays, deductibles. And so if a Medicare beneficiary does not choose a managed care program, then they're not placed in one. Okay, they have to choose it. And so whereas a Medicaid beneficiary, okay, when they enroll in Medicaid, the state automatically puts them in a managed care program. Whereas a Medicare beneficiary, they have to choose to go in a managed care program. And so a lot of them don't choose to go in a managed care program, and that's their prerogative. They just pay for whatever they want. And so what the government does is they put managed care packages together in the form of Part C. I had talked about Medicare Part C being that hybrid plan to where Medicare beneficiaries, they choose the type of program that they want. So the government, what they do is they just make managed care programs more enticing. And so you see right here over the past 5, 6, 7 years, you see an increase in the managed care programs through Medicare. You see it start to increase because the government's just trying to make it more appealing to managed care, or sorry, to Medicare beneficiaries. And again, we'll talk more about it in class. The book does a good job. If I'm getting tongue-tied on this, and or if I'm just talking too fast, the book does a good job of laying that out. But definitely ask questions in class, and I will be and I'll make sure again to make sure that I go in detail about this. Okay, if that doesn't make any sense. Part D is the prescription drug benefit. Okay, and we'll get into that in class. But the prescription drug benefit is very, very, very popular with Medicare enrollees. Very popular. Obviously, because when you get older, what happens when you age? Chronic disease becomes more prevalent. And how do you combat chronic disease? Well, you need your medications. And so a lot of elderly take a lot of medications. And you know who else is very fond of the prescription drug Part D plan? You know who else likes it? Pharmaceutical companies. And we'll discuss that a little bit more in class. This right here is what's called the donut hole. I don't know if anybody's ever heard of that before, the donut hole in the prescription drug plan of Medicare Part D. And we'll talk about that in class a little bit more. Basically, in a nutshell, when you get Part D, okay, when you pay for it, because you have to pay for it, there's a $310 deductible, meaning that when somebody elderly, when they go to Walgreens, let's say, and they pick up their prescriptions, the first $310 comes out of their pocket directly before the government kicks in and starts paying for anything. Okay, once a Medicare beneficiary reaches that $310 deductible, then the government starts to pay 75% of their costs. And of course, the enrollee pays 25%, but the government picks up a big tab until the government has paid $2,840. Once they reach that ceiling, the enrollee pays a huge amount out of their pocket. And we'll talk about this in class right here. Just know that there's a donut hole in it, meaning that a large part of prescription drug costs, once you meet a certain deductible, a large part of those costs come right out of the beneficiary's pocket. And so what Obamacare, if you will, or the Affordable Care Act tried to do is that it increased the amount of money that the government will pay out in prescription drug benefits. So what they did was they took this right here and raised that ceiling to somewhere up into here. And don't worry, I'll make a nice graph for you when we get into class. I mentioned this earlier. This is just talking about the amount of workers in our United States workforce, the amount of workers per beneficiary, meaning that how many taxpayers do we have that are working, paying into the Medicare tax versus how many people are actually using that Medicare money. And we'll talk about that more in class. The government as a health insurance regulator. The government, of course, passes a lot of laws, right? Some to try to help, regulate who gets access to certain types of care. The government passes laws to try to regulate cost increases. A great example of the government as a regulator, just look at the Affordable Care Act. Okay, putting out all those provisions on health insurance and who can get access, and trying to curb the rate of cost increase with the healthcare system. Okay, and that's just not the federal government. The state government also regulates, plays a hand in being a health insurance regulator. If anybody is an allied healthcare professional or knows anything about physicians and what they can and can't do, the state regulates it. The state regulates medical professionals because they have to get licensures every year. States also set certain rates for certain types of health insurance or healthcare services, and states also oversee healthcare quality. when you get um, like at the hospital level, for example. There are the Duval County Health Department in Duval County will go in and will do health inspections for hospitals to make sure that they're up to code, right? To make sure that they're safe, to make sure that they're clean, to look at infection rates. Okay, they try to oversee quality in healthcare settings, and so that's all at the state level. The role of government as a healthcare provider, okay, through the VA clinics, right? Hospitals, rehab programs. The VA, of course, meaning the Veterans Affairs. The government also supplies health insurance to active military and retired military through TRICARE. Okay, so in the United States, our government as a healthcare provider is not as large as, say, if you go to the UK or to England, where their government as a healthcare provider is their healthcare system, right? It is the national health insurance model. All the hospitals are funded and they're all employed by the government. They're all government agencies. And so you walk into a hospital, you walk out of a hospital, you don't pay for anything because it's all paid for by the government. Versus here in the US, the government as a healthcare provider is very, very small compared to our private hospitals and private health insurance. So paid for through private health insurance. So and again, we'll get into that in class a little bit more. We'll get into some of the controversies with the government being really a healthcare regulator, provider, and insurer. One of the there's three major issues with the U.S. healthcare system. Okay, it's cost, quality of care, and access to care. And one of the big, I guess, what's looked at on the national scale, one of the big sort of injustices with our insurance in the U.S. and also with the quality of care in the U.S. is that the quality of care that a Medicaid patient gets is by far less than the quality of care that somebody with private health insurance gets. And the reason why that is because what a physician is reimbursed through private health insurance is much more than what a physician is reimbursed through Medicaid. So it's like, we have all this money in the US, okay? And if you have money, you get the best health insurance and you get the best care. If you don't have money, for example, i.e. if you're poor and on Medicaid, you don't get great quality of care. And there's numerous studies out there that show life expectancy and just overall quality of medical care when you're admitted to the hospital for somebody who is on Medicaid is far less than quality of care and life expectancy for somebody who has private health insurance. And that right there is one of the big, just a big injustice with the U.S. healthcare system, is that we don't do a good job of taking care of the poorest and the sickest within the U.S. healthcare system. And we're going to spend some time talking about that as well as we move forward. The Affordable Health Care Act, which we will talk about after we talk about private health insurance in Chapter 3. So we're going to come back to the Affordable Care Act. But to get ahead of the game, if you go to Blackboard and you go to hopefully this is going to pull up right here. Our documents and resources, and you come down here into some videos that I have. This is, and we're going to watch this in class, but just to give you a heads up, this right here does a great job of explaining the Affordable Care Act. It's an animated video, makes it very, very understandable. This video right here talks about Medicaid. This one talks about Medicare. And these two right here talk about how private health insurance works. So some extra videos in here for you to watch to get a leg up on the book resources. So that's it. And any questions, just make sure you ask them in class.